Let's talk about cytomegalovirus, parvovirus, varicella, and toxoplasmosis. Some background. CMV is a double-stranded DNA virus sexually contacted or direct contact with infected blood, urine, saliva, 40 days incubation period, and IgM will be produced. Primary infection up to 4% of pregnancy, secondary infection up to 15%. Vertical transmission route is transplacental. Most significant risk for clinical sequelae. Greatest risk of transmission in the third trimester. Primary infection risk of vertical transmission. In primary infection, the risk of vertical transmission in the first trimester is 30%, and the most serious sequelae occur in the first trimester. In the second trimester, it's about 40%, and then in the third trimester, it's 70%. So in the third trimester, it's most likely to the risk of vertical transmission is the highest in the third trimester. However, the sequelae is the most serious in the first trimester. 20% infected in the utero will have symptoms at birth and develop sequelae. 30% with severe infection will die, and 70% survivors will have neurological morbidities. (2% vertical transmission after a recurrent infection. Most severe sequelae is congenital hearing loss. This is just the reinfection, recurrent reinfections. Only 2% vertical transmission rate. Other transmission route is genital tract contact during delivery and breastfeeding. Most infants with congenital CMV are asymptomatic at birth. Congenital CMV clinical features: jaundice, petechiae, thrombocytopenia, hepatosplenomegaly, FGR, myocarditis, non-immune eye drops. This is the most common congenital infection, up to 2% of neonates. Let's go down to diagnosis. Serum sample collected 3 to 4 weeks apart. Test for anti-CMV IgG. Seroconversion or 4 times increase in titer is diagnostic. IgM presence and low avidity IgG consistent with primary infection in the past 2 to 4 months. Sensitivity of CMV IgM alone is only around 70% for primary infection. So we need to see low avidity IgG. Fetal CMV suspected after ultrasound finding. We'll see liver calcification, hepatosplenomegaly, echogenic bowel ascites, cerebral ventriculomegaly, paraventricular calcifications, and microcephaly. So these calcifications are around the ventricles. Aminocentesis for detection of CMV with culture or PCR. Detection of CMV in amniotic fluid does not predict severity. There is no treatment. Ganciclovir is FDA approved only for AIDS patients or organ transplant patients. Serial ultrasound surveillance with assessment of fetal anatomy and growth is performed. So that was CMV. Next we'll go to parvovirus B19. It's a single-stranded DNA virus, cause of exanthema erythema infectiosum in kids, or fifth disease. Patient have these kids have slapped cheek, fever, body rash, and joint pain. Adult infection, reticular rash on the trunk and peripheral arthropathy. Aplastic crisis in people with comorbidities. Spread by respiratory and hand and mouth. Infectious for 10 days after exposure, before the rash develops, and no longer infectious when the rash appears. IgM persists for 1 to 3 months. IgG persists forever. After acute infection, rate of vertical transmission is about 30%. Spontaneous abortions. Hydrop fatalis, 20% of hydrops are caused by B19. Other diseases, aplastic anemia, myocarditis, and fetal hepatitis. Unlikely to develop after 8 weeks of maternal infection. Stillbirth, 20% before 20 weeks, 5% if after 20 weeks. Can occur up to 10 weeks after maternal infection. Possible neurodevelopmental impairment. More severe features are seen when the infection is prior to 20 weeks. So for Parvo, it's mostly aplastic anemia and hydrop fatalis, and stillbirth, I guess. Diagnosis: IgM positive, should be monitored for fetal infection. IgM and IgG negative should repeat in 4 weeks. If either turns positive, monitor fetus for infection. Fetal infection diagnosis using PCR in the amniotic fluid. Management: monitor for development of fetal anemia with serial ultrasounds performed every 1 to 2 weeks for 12 weeks after exposure. If no ultrasound evidence of fetal sequelae after 12 weeks, unlikely to have any adverse outcome. Fetal death can occur without hydrops. If hydrops, fetal blood sampling should be performed to determine hematocrit for possible transfusion. Limit to exposure is not realistic. 20% of infected are asymptomatic. Next, we have varicella zoster. It's a DNA herpes virus transmitted by respiratory droplets or close contact. 14 days incubation period. Can be infectious 48 hours before the rash and lasts until the vesicle crusts over. 20% of pregnant women with VZV infection can develop pneumonia. Highest risk of neonatal death when the maternal disease is 5 days before delivery to 48 hours postpartum. This is due to immaturity of neonatal immune system and lack of maternal antibodies. Varicella immunity should be documented or IgG serology done. Fetal varicella can be indicated by presence of ultrasound abnormalities after acute maternal infection. PO acyclovir can be started within 24 hours of developing the rash. It can reduce the duration of new lesions. Varicella zoster immune globulin should be given to infant born to women who got varicella between the 5 days before delivery and 2 days after delivery. VZIG. Conception should be delayed for 3 months after the last dose of live vaccine. However, exposure to vaccine is not a reason for termination. Pregnant women exposed to VZV should receive VZIG within 4 days of exposure. Up to 10 days may be given. Should ask reproductive women about their VZV exposure or vaccine before conception. Next, we have toxoplasmosis. It's a intracellular parasite. Cervical lymphadenopathy in 20% of infected, fever, night sweats, myalgia can occur. Up to 50% congenital transmission without treatment. 50% transmission in first trimester. 25% in the second trimester. 60% in the third trimester. Early transmission equals more severe disease. So this is the same as CMV, even though it's a parasite. So early transmission equals more severe disease, but vertical transmission is more likely in the third trimester. Congenital Toxo clinical features. You can have chorioretinitis, severe vision impairment, hearing loss, severe neurological development delay, rash, hepatosplenomegaly, ascites, fever, paraventricular calcifications, ventriculomegaly, and seizures. IgM, IgG can persist for years. So, diagnosis of Toxo, IgM, IgG should be the first step if suspecting infection, IgM negative, IgG positive, there's no concern. If IgM and IgG is positive, could be a false positive, repeat in 3 weeks. Increase in IgG titer equal recent infection, low IgG avidity, infection is less than 5 months. Fetal toxoplasmosis, ventriculomegaly, diffuse intraventricular calcifications. So this is diffuse intraventricular calcification. Intracranial calcifications. Microcephaly, ascites. So Toxo is diffuse. CMV is periventricular. Aminocentesis for fluid PCR. Management in the presence of acute maternal infection. Spiromycin to reduce placental parasite transfer. However, this is a macrolide, however, it needs FDA help to obtain. Fetal infection, you treat with pyrimethamine, sulfadiazine, and folic acid. Prenatal screening for Toxo limited to women with HIV or immunosuppressed.